So okay, this is about the lumbar puncture thing. So this is a potential 3 marker question which is being asked. So whenever there is a investigations which is being asked, make sure you write as these are the questions which can come for 3 marker. So you can have indications or contra. You can get question based on indication or contraindication. So while writing indication, make sure you write diagnostic or therapeutic. Obviously, if it's a therapeutic, then it should have high CSF. So where do you find it? In benign intracranial hypertension or whenever you're giving drugs. So diagnostic, obviously you are studying now just now meningitis, SAH and all those things. Contraindication, whenever you are writing, divide it into absolute and relative. So based on that, you have all the things which is mentioned earlier. It's the procedure not required. Complication, yes. Divided into immediate, early, late. Obviously, if it's a traumatic type, then it's happening at that point of time, so it's immediate. Then these are the early complications, and these are the late. Status epilepticus, potential 5 marker. This is the definition. And always while writing any emergency case, what you have to write first: emergency, that is airway, breathing, circulation. Check for all these things, then secure IV line, and also send all this for investigations. And if it's more than 5 minutes seizure, then obviously first thing what you do in emergencies, you have to rule out hypoglycemia. Then what you do is you have to start with what we do is we start with intranasal mida, that is midazolam, the 0.1 mg kg body weight. Then we do it twice till we get the IV access. But once we get the IV access, we start with lighter acetam. Again we repeat. Again, if you are unable to manage, then we go for when we shift the patient to ICU. So based on that, first is midazolam or lorazepam. Again, if it's continuing, then you start with IV infusion of any of these. Then if it's severe, then you have to go with valproate. Then if it's responding to none, then it's a refractory status epilepticus, for which you need to do intubation and use anesthetic drugs. Okay, but major thing is this is the tape. This is the thing which is given in Davidson. So while investigating an epilepsy case, you need to address two major things. That is, from where is epilepsy arising and what is the cause of epilepsy. For that, you need to do the EEG. Okay. Then to know the cause, whether it's structural or metabolic or infective. Again, you start with infective because that's how you remember based on the Robbins pathology. Infective, then structural and metabolic. So I have this in mind while writing investigation of epilepsy. Then complication, again acute and chronic. Make sure you know the chronic part of this thing well. Same thing, because it's a CNS thing. You have to write about neurology. Then obviously behavior will get affected, and also all in the acute part, make sure you write all the systematic thing. Then Bell's palsy, it's a potential 3 marker question. While writing clinical feature, make sure you draw the diagram. Okay, you draw the diagram and show all the clinical features which is present. And also while writing clinical feature, make sure you write like this. As I told, write it generally, then motor features, sensory features, autonomic features, and if there are any associated things. Then again, treatment, you have to treat the disease and prevent the progression and prevent the complication majorly. That is you give artificial tears and eye patches. Okay. Then migraine headache, potential 5 marker, not for a 10 marker question as per I feel. 5 marker or 3 marker for sure. This is the definition. And how do you what is the natural history of disease? First, you get prodrome, can be either visual, sensory, or speech. Then you get that aura. First you get the prodrome, that is mood changes, food cravings, or fatigue. Then you will get, it might be associated with aura like visual or sensory or speech. Then you will definitely have headache. That's the main thing. That is pulsating, throbbing, unilateral headache. Then you obviously will have post-dermal fatigue or instability. What do you do in an acute attack? You need to reduce the pain. You need to treat the nausea. Then if it's severe, you have to give subcutaneous sumatriptan. Then for prophylaxis, you go consult a neurologist. Then based on that, they will decide which to add you as a prophylaxis dose based on your body profile and all those things. But these are the drugs which are usually used as prophylaxis. That is beta blockers, antidepressant, anti-epileptics. If it's refractory, then you have to go with CGRP, because that's where we have narrowed down the pathogens of migraine at this stage. Then causes of ptosis, this is what was given in Davidson. I just copied it. You have to do so basically you have to know what are the things which maintains the high normality at the proper stage. So based on that, you need to draw. It might be due to muscle, it might be due to cranial nerve, or it might be due to the sympathetic activity. So based on that, it might be due to central cause or a peripheral cause. So if it's a peripheral cause, again, whether it might be due to in the lung or it might be in the carotid artery. So based on that, make sure you know that. And myopathy, most common myasthenia gravis is diagnosed based on ptosis only. So you need to know about that. Then also the third nerve palsy, it might be isolated or it might be due to some supranuclear palsy. Parkinsonism, again 5 marker. So that's what I'm saying. I cannot keep on explaining everything, but I've given you the notes. And in this video, I'm just explaining what to study and what not to study. That's the aim. But if you have any doubts, you can always contact me. Okay. So clinical features, again, it's a motor predominant disease. So any CNS diseases are either sensory predominant, motor predominant, or it might be combination of both. And again, you have the infective part, malignant part, all those things. So it's a Parkinsonism. This is how we have to present the clinical feature, that is motor, non-motors and others. Again, in motors you have this mnemonic called trap, where you have tremors, rigidity, akinesia and postural instability. And again, while writing non-motor, address autonomic component, sensory component and any other component which is present, which I told in the general clinical features while writing CNS. And again, investigation is a clinical diagnosis. You do in young patients, you have to think of any other cause. So for that you do CT or MRI. In treatment, pharmacological, non-pharmacological, and if it's refractive, then you go for surgical deep brain stimulation. Okay, non-pharmacological, you need to patient, again, you're going to write the aims, that is to reduce the disease progression, then to prevent complication, and to give a healthy, functioning life. For that, you go with physiotherapy, occupational therapy, or speech therapy to increase the functionality of the person. Okay. Then this is the one more thing, that is myasthenia gravis. Definition, obviously you can go through that part. That here what is happening is there are there are antibodies against the ACH receptor, so it's getting destroyed. Okay, right about that. Again, while writing clinical features here, what is happening is that it's affecting muscle. So understanding the natural history of disease is important. It is affecting the eye muscle first, then it affects the bulbar component. You have to write about the bulbar component, that is dysphagia, dysphagia, all those things. Then limb, it affects proximal more than distal. Then this is how patient dies. So you need to know about that. Investigation, again, to diagnose the disease, and whenever you are in doubt, go for hydrophobia challenge, which I'm sure you have studied in pharmacology. Then again, to look for complication, again you have to check whether it's an autoimmune condition, so you have to evaluate for thymus, and also you have to do electrophysiological test whether nerve connection studies are being maintained to look for any other complication which might go into respiratory failure. Again, serology is the mainstay, and routine lab investigations like ESR CRP to know whether it's an inflammatory thing. Then management, again, the goal is to maintain ACH and to prevent the abolition of immunological attack on motor input. For that, you can go with to increase the ACH. What do? You give AC inhibitors or immunotherapy. Then again, if based on CTVS oncology review, you can go for thymectomy if possible and feasible, and whether if it is beneficial to patient. During a crisis, make sure you admit the patient under ICU, do have a mechanical ventilation, and to Plex or IVIG. These are the supportive care which you need to study. Causes of hypotonia, again, CNS, PNS, metabolic and miscellaneous. Divide it and just write it down. Obviously, you know CP and HI, pediatric things. And again, PNS, what is PNS? From anterior onset till the muscle action is PNS. So based on that, you can write one thing for all. Then metabolic, obviously you can have hypothyroid or electrolyte abnormality causing that. Then miscellaneous, that is you inducing it via skeletal muscle relaxant or all those things. Then trigeminal neuralgia for a 3 marker. Prevent the trigger, and management is what is the drug of choice is something which they ask, that is carbamazepine, and also you can use gabapentin or lamotrigine. And these are the surgical options which are there, which are not being done for sake of exam. You can just write which are being done in refractory cases. Okay, to prevent pain, you can give NSAIDs. Okay, this is the secondary prevention of stroke, which is given in Davison. This is just a 3 marker. First, what you do is first you do CT, identify it as a hemorrhagic or ischemic. Then you lower the BP based on that. Then if it's hemorrhagic, obviously you have to talk about lifestyle modification, and you check for ECG and carotid pulse duplex to know where is the thrombi coming from in case of ischemic. Then you need to do you need to give statins and aspirin and anticoagulation throughout the life. Then that's it about CNS. CNS, it's a vast thing, but you're studying it from first year, so you need to know how to put it, how to place things in features. So know the template of clinical features first, template of investigation first, template of treatment first. Based on this, classify the disease into infective, non-infective, and again you have traumatic causes like SAH. Then you have neurodegenerative causes like Alzheimer's and Parkinson. Make sure you place those diseases and make sure you write it in the same way as the clinical feature which I have provided. The dermatology and psychiatry, which I am sure you should go. This is a game changer because many would have left for the fact that uh, it's a major question part. That means you have to study a lot. There are a lot of RS questions in this part. So for conceptual understanding, you can just refer this video, which I'll be uploading in the description box. So make sure you structure your answer just to 5 marker, 3 marker only, because these are the only 2 questions which you get. So the questions which you can get are eczema. The major question which you need to know is about the psoriasis thing. So psoriasis, again, go with the definition, and you should know the type of psoriasis. So based on the type of psoriasis, plaque psoriasis, guttate, and erythrodermic and pustular. So make sure you write about it and you just explain it. And also on examination, you have to write about the nail changes, which is pathognomic of psoriasis. So you need to mention about that, and also about the auspic signs. Then how do you manage? Again, this is what is given in the Davidson part. But for 5 marker, if you write this, then it's more than enough. But make sure you write the general management by giving emollients and topical vitamin D analogs as well. Then again you go with PUVA. Again, if it's required, you go for IP admission. Then you start with systemic antibiotic, or if in a refractory case, you go with this thing. Then for 3 markers, you might get questions like what is the conditions which are associated with erythema nodosum, like for example in TB sarcoid and streptococcal infection. Then next important thing is scabies. It's a potential 3 marker question. So know the organism. Then again, what are the clinical features? Here you have to just talk about skin lesions, and if there are any systemic thing. Again, you are studying from second year, so I don't think there's much to explain here. These are the other possible lesions which you can find, and how do you diagnose it, and this is the general management. Make sure you treat the close contacts as well. This is what something which I expect even examiner expect you to know, because everybody will write permethrin and sulfur. That's what everybody will write, but you should know how do you differentiate you from the rest of the people. And oral therapy is ivermectin. For symptomatic, obviously you give ciprocin and steroid to reduce the thing, and also environmental decontamination. Okay. Then generalized pruritus, that means you're having itching all over the thing, all over your skin. So make sure you write about the systemic cause. For that, I've just made a mnemonic like climbs. For C stand for cholestasis, L for lymphoma, I for iron deficiency anemia, then C for CKD, and S for systemic conditions like HIV. So here you have to treat the cause. Okay, general management, everybody will write that is cetirizine and steroids, and at the end phototherapy. But major thing is you have to write here they will ask you about the etiology. So obviously you are talking about dermat, you have to know about the dermatological condition like atopic dermatitis, xerosis, then also systemic cause. Then also there might be somatoform anxiety. That means a patient is visiting multiple doctors but unable to find out the etiology, what is happening. So that is an important thing. And also some drugs like opioid and ACE inhibitors. So this is for a 3 marker. Okay. Generalized pruritus. Eczema is a potential 5 marker. So what is that? It's an inflammatory skin disorder. It might be either endogenous or exogenous based on what is happening in the. But though the pathogens remain the same, it can be either endogenous or exogenous. These are the initial management steps. I have just copied it from Davidson. The same thing. You have to in dermat. No, you have to fill the pages, man, if you ask me directly. And also I have to write general treatment. What do you do for next step? What are the considerations which you go? There's nothing much. You have to do the accurate diagnosis. Then you have to go start with emollients. Everywhere you can write, okay, emollients, that is moisturizer, all those things. Here the major important thing is you have to do, at the end, if it's not responding to all these things, then you have to go with PUVA. Then you have to consider immunosuppression. Any pattern in management of dermat, make sure you write it, except infection. If it's an autoimmune condition, first make an accurate diagnosis, establish severity, and remove that trigger. Then the general treatment approach with vitamin D analogs or emollients, all those things. Then next step you go with PUVA, all those that is phototherapy. Then you can consider all those things. So general approach is same, but make sure you fit everything into that piece. Okay. Then urticaria. So it's a localized dermal edema due to temporary increase in the capillary pressure. So it might be due to physiological, immunological cause, non-immunological cause, broadly speaking. Okay, this is the most common, that is IgE mediated. There's nothing to explain here. You have to just know things and you have to go. Again, while writing causes, you have to know the infection. As I told, go with the Robbins pathology. But here, majorly, since it's an immunological cause, the classification here is based on immunological and non-immunological. Though under infection, you have viral things, and under SLE and vasculitis things. SLE and vasculitis is also there. Then vitiligo, obviously it's that it's something to do with pigmentation. So they might ask you about the pigmentation diseases. So make sure you study this table and go as well. Then vitiligo, again, medical management and again, as I told, medical phototherapy and consideration. So dermat, by writing management, the protocol remains the same. Make sure you fit it into the picture, provided you rule out all the other like infective and malignancy part of it. Okay. Then they might ask PUA therapy for 3 marker. Okay, what do you do? This is the mechanism of action. It causes cross-linking and causes immunosuppression. With that, you also give a photochromotherapy. That is photochromotherapy in a photosensitizer. Yeah, with you will apply a cream, then you will give a phototherapy. That's what it is. Okay. Then indication, all autoimmune condition which affects skin, you can write, nothing less, nothing more. And acne vulgaris, in and out, I think you would have studied, and girls know many much more detailed than this part. Again, open or close comedones. Obviously, for this you will apply salicylic acid, which I think all of you know. If it's an infective part, again you will do it. Obviously antibiotics. So these are the general measures which you need to know. Then retinoids or benzoyl peroxide if you have been infected, and systemic therapy in stage 3, stage 4. Make sure you know the classification part very well. Okay. Then again you have all these procedures, which is, if you want, if you have time, you can have. Then this is a potential 5 marker or a 3 marker, where you will talk about SJS or TN, that is toxic epidermal necrolysis. Again, it's nothing but you make sure you know the classification. SJS at the end will turn into TN. So for remembering, I just made one mnemonic called SCALP, because we are studying about dermat. S for all the sulfa drugs. Then C for carbamazepine. A for any NSAIDs. Okay, I just made sorry, anti-epileptic. L for lamotrigine and P for phenytoin. Though NSAIDs are also common offender in this SJS. So these are the clinical features. Nothing you have to mention about Nikolsky sign. And also, while based on case, you are either go with IVIG or cyclosporine. So while studying dermat, make sure the management protocol is same for all except infective, that is scabies, which is the most important thing. Then make sure you know the template and you fit those diseases in the template. And while writing scabies, if scabies comes as 10 marker, make sure you write the management part really well by mentioning all these things. Then again, general overview for 3 marker, we cannot predict, but these are the questions which are being consistently asked. Okay. Then coming to psychiatry part of it, which is also a potential 8 marker. So psychiatry and dermat, again you have two things, that is one is 5 marker or 3 marker. So these are the 3 markers. Again, you might get or might not get. The major thing which you need to focus here is on schizophrenia and severe depression. So dementia, as I told, I explained in that part as well. And also these are the potential questions which can come. So schizophrenia, again, there is nothing. Again, there is also a template here. So here for schizo, this is the clinical feature of you right now, because based on this only you have the diagnostic DSM-5 criteria where you diagnose whether the person has schizo or not. So again, you have positive symptoms, negative symptoms, and other symptoms. So where I have made a mnemonic of ABCD for positive. Then these are the negative symptoms, and there might be associated catatonia. And also etiology, while writing any psychiatric things, you can divide it into, it's again community medicine, genetic, environment, and social things. So based on that, you can make a triangle and also explain based on the marks which they are asking. If they are asking for less marks, don't waste time on etiology. Okay. Then again, this is the criteria. There's nothing to explain this criteria, you need to know. Okay. Then this is the management protocol which we follow. Then paranoid schizo is a subtype of schizo which is characterized predominantly by delusion, okay, and auditory hallucination. Then these are the side effects of antipsychotics. This can come as 5 marker or 3 marker. Make sure you know it very well. Okay. Again, since it's something to do with CNS part of it, so you have to write about the pyramidal and extrapyramidal symptoms. Then neuroendocrine, this is the major thing. Okay. Then any autonomic disturbance and any serious life threatening thing which you need to mention. And mood disorder, depression. This depression alone treatment can come as 5 marker or 3 marker, or independently anything like proper depression can be as for 5 marker. Again, while writing this thing, as I told, genetic, environment, and social factors you have to mention. And then you need to know about the diagnosis criteria. That means you should have any of these 5 symptoms any of the 5 of the following symptoms which I have mentioned here for more than 2 weeks of period. Okay. Then you will be diagnosed as depression. I think this is also something which you can write on your own, that is antidepressant and psychological, and if it's refractory then go for ECT. Okay. Then mood disorders, I think you can just read upon bipolar. Bipolar is both mania and depression, so you need to explain about that part. Then here your treatment mark, major aim of investigation here is to rule out hyperthyroid. Okay, that is one thing which you need to remember. Then treatment here is again second generation antipsychotics and mood stabilizers, because I have to treat both psychiatric as well as depressive. Okay. So in anorexia nervosa, yeah, it's a potential 3 mark command. So because of the fact that it's becoming more common, and something you have something related to medicine. So anorexia and bulimia are not the same. What happens in bulimia is you do binge eating. Either after that, followed by, you will either do self vomiting, or you do some strict diet and you lose the weight. Okay, here you will have dissatisfaction with the body shape and all those things. But this is the major thing. You will have pitted, and in the knuckles you will have all those things. Management is again by cognition based therapy. Here the management is the same for both. Okay, if there's associated depression, you will treat that here. But in anorexia nervosa, what happens is that you avoid food, man. You won't do anything. Here you at least eat and you vomit, but here you don't eat only. Okay, that is you. That's the same thing. Clinical feature. What are the associated things? Then also, while talking about this thing, as I told, community medicine should come into play, social environment and genetic. Okay. Then ECT. These are the, just study the indication and go. All refractory thing you give the ECT. All diseases refractory, write ECT and come. That's it. Nothing less, nothing more. Then panic disorders. I think this definition, if you want, you can remember or you can leave, because if it's a 5 marker, then you need to write. If it's a 3 marker, need not be. Okay. Then again, what are the things? Again, divided into system. Then treatment is again psychotherapy, that is exposure therapy. So whenever, if they are getting scared in particular moment, make sure you expose them to that threshold and leave. Then higher threshold, leave. Higher threshold, leave. That is what is the major thing which they expect you to know. Then antidepressant and cognition based. Then obsessive compulsive disorder is also something which you can just read and understand. Lithium, again, here they will ask you about the indication and adverse effect. Okay. Then again, this pharmac thing, make sure you know the mechanism of action. Based on that, again, indication is basically it's about mood stabilizer. So any mood disorder, you can just write it up. Okay. Side effects, again, you divide it into common and long term. Make sure you write hypothyroid and nephrogenic DI, the major important thing, and also contraindicated in pregnancy. Then what about puerperal psychosis? That means a woman after a puerperium, that is during a puerperium, that means after childbirth, if she has all these kind of psychiatric symptoms, then it's called as puerperal psychosis. This is the management thing which you do. So psychiatry is nothing but, as I have told, see, dermat and psychiatry as a template. So they don't expect you to know everything, but you need to fit all those diseases into the template, and clinical features and investigation and treatment. Make sure you know that and fit it into a template and make it a proper presentable thing, and add few things from whatever you have studied and place it and come back. Nothing less, nothing more, because you cannot sit and study psychiatry and dermat a day before exam. These are some of the important topics which I have discussed. Make sure you study these things and go. That's it. That's it about psychiatry. Next, coming to the most important system, that is RS. Okay. If you know, as I told, if you know CNS, CNS and RS part of CNS, RS and MAT and infectious medicine well, then you will pass the paper. Okay. So coming to the weightage, that is 19 marks. So this and this are interchangeable. So I think you know what are the diseases which are there in chronic respiratory disease. So these are the questions which is present here. Okay. First, I'll go with the pneumonia part of it, because it's a case-based scenario. Okay, one question has to come as case. I have not discussed in paper 1, but it's understood that we are a CBME batch, RS4 batch, that one question has to come as a case-based. So while writing the diagnosis format, make sure you write the anatomical diagnosis, pathological diagnosis, and whether it has complication, and also what is the probable source of etiology. Okay, this is main. And if you see, what people write it, they just write pneumonia. Okay, wrong. You have to write right upper lobe pneumonia. Okay, then with complications such as shock or something like that. So make sure whatever you say it in your case discussion, make sure you write a diagnosis same. Etiology same. I've just copied from Davidson. This is how the pathogenesis goes. That is the same patho thing: stage of infection, red hepatization, gray hepatization, and resolution. And again, clinical feature. This follows a template of your lost. That is paper 1. That is generalized systemic. Make sure in systemic you divide it into without complication, with complication, and these are the common sense clinical symptoms which you write. Then while writing examination findings, if it's a 10 marker, make sure you write all inspection, palpation, percussion, auscultation, which I'm sure you would have discussed n number of cases of pneumonia in your case discussion. And again, investigation objective is to confirm diagnosis, assess severity, and to identify the development of complication. This is something which is very important because the mortality is high in pediatric population as well as old age. Okay, management aims again, all these things which I mentioned, you can write it here. CRUB 65 itself alone is a standalone 3 marker, or you have to mention. So what does C stands for? C stands for confusion. This is the first thing which people will forget. All will write about urea and breath rate, then respiratory rate, and BP also something which you get confused with one, but it's not. 65 is age. So if it's one, you go for OPD management. If it's two, consider hospital supervised management. But for 3, obviously you'll admit into hospital. But for 4 to 5, you have to admit into ICU. So these are the investigation names which I talked. So obviously I have to talk about fluid balance, then antibiotic therapy. Make sure you write about according to British Thoracic Society. Either go with this. Okay. Then if there are any complications, then you have to read the complication. These are the complications which I mentioned. Asthma part, yeah, this is the definition. And sorry, I thought I would write the part of physiology. Though it for 10 marker, if you come, you have to write. I'm not written it here, but make sure you know that part. But I have to discuss this part well. Okay. So latest guidelines is GINA guidelines. So I think it's 2024. So make sure you draw this. What is this? It's a histogram. Yeah. Again, you have to diagnose the asthma. Then you start with low dose ICS. Then again, you add LABA with low dose ICS. Then you can think of considering increasing ICS because it's an inflammatory thing. Okay, so ICS is the mainstay. Then if it's being refractory, then you can consider referring. Okay. Then also one more thing. I'll come to status asthmaticus. Again, clinical feature. Again, general systemic, as the narration flows as the same narration which paper 1 follows. Okay. Then again, investigation. It's a clinical diagnosis to assess the severity and to look for complication. You go with the investigations. Okay. This is like the for a day before exam. I just followed this. Then this is the acute severe asthma thing. So first you need to. I request you to draw this part which is given in division. So first what we do is first we measure the peak expiratory flow rate. It might be from 0 to 100, correct? So if it's from 76 to 100, that means it's moderate. Okay. So again you have to check whether the patient has taken the Livolin, that is the salbutamol, whether he has taken it before or not. If he has not taken, then you can ask him to inhale the bronchodilator and wait for 60 minutes, then go back. If it's yes, then again you have to repeat the BAF after 30 minutes. Okay, that's the major thing. But if it's from 0 to 75, you maintain the same thing. That is, you go with the ABG and nebulized salbutamol thing. Then again you measure the PF. Then you admit the patient. Then you start with ipratropium bromide and all those things and continuous salbutamol infusion. Then if it's refractory, then start with IV, that is magnesium. Then you have to correct all these things. Make sure you study this part and go. Okay. Make sure you know this part. Okay, this is something which you should know. And if they ask for status asthmaticus management protocol, make sure you write this, you present this, and you come. Okay, because this is the thing which is given in division. Then based on that, I just added few things here. That's the same thing which I copied, man. This is how to assess the severity and all those things. Okay, but this is the main. This is the key. I think there is a latest guideline also. Just cross check. Okay. Then these are the complications. Again, all the systemic complications. I'm sure you know it. Then coming to pneumothorax, that means there is what? Air in the thoracic cavity. Okay, so it might be either spontaneous or traumatic. Again, this is what is though pneumothorax has been a surgical topic. I don't know why they've asked it, because of these risk factors, I guess. Okay, these are the clinical features. And as you know, what are the two things which makes doctors kind of hero in public? That is treat hypoglycemia or treat pneumothorax. Treat pneumothorax, right? So this is the management. I'm sure you know from any decades. I mean, I'm sure you know this part. There's a clinical diagnosis to assess the severity. You check for whether he has hypertension or all those things. Then you see the age. Then you start the treatment. Then I'm not explaining it provided so that the first of all, this is self-explanatory, and I'm sure many of you know it, so I don't want to waste time. Aim is to know say me things where there are concepts, and just leave those parts where you can study on. Then pulmonary embolism, it's a 5 marker question. Okay, these are the causes, nothing much. Then dividing into types, that is acute, small, and chronic, is something which is important. Make sure you study about the Wells criteria, Wells score for 3 months. Okay, that is I'm sure you know it. Okay. Then again, investigation to exclude other causes. This is very important. Then to support, then to diagnose, and to further manage the patient. So this is the algorithm which you need to follow. Okay. So what you do is, first you have to do the Wells scores. Then you have to check the score. If it's like more than 4, then it's likely. So you have to do the CTPA. Then you have to start on anticoagulation. Still, if you suspect, you can start one, because the patient won't die because of it. But if you don't treat, the patient will die. But if the D dimer is negative, then you can consider alternative diagnosis. But if it's a positive T dimer case, then you need to do a CTPA. Okay. In hospital acquired pneumonia, go with the same narration, but the but the etiology and the treatment part will change. That's it. Then you write the same thing. So I'm not explaining much. So bronchiectasis, again, it's a abnormal dilatation. Again, it can be divided into congenital and acquired. Nothing. Nothing. There's nothing to explain in this part. See, RS and CVSC and GI hepatobiliary and CNS should should you, when you are studying those things, you should have a smooth narration. That means there's nothing for me to explain, because they have already I have seen many cases, so you know what happens in ward and all those things. So these are the clinical features. I'm not talking much because I'm sure you know this. Okay. So, but what are the things? Again, I think this part also, again, management aims, you need to talk about. Again, all these things, where it is getting involved, whether it's a patient for surgical resection or not, then all those things. But one important thing which I will mention is, whenever you do for an auscultation, obviously you will hear chest sounds, that is in sounds, that is what you hear. And also you hear extra added sounds. So if it's extra added sounds, if it's present, if it's due to airway, then you hear bronchi. Either you see in asthma or COPD. Okay. Then if it's due to interstitial, you can either hear coarse or fine crackles. If it's fine velcro crackles, then it's ILD. If it's coarse, then bronchiectasis. If it's fine, then you can either have pneumonia or pulmonary edema. So this is how it goes. Okay. So know this template and fit it every place. You fit, inspection, palpation, percussion, oxygenation. Based on that, you enlarge your case. Okay. So now this is a potential 3-marker side effects of HRZD. This is what is given in Davidson, so I just followed it. Classified as major and less common things. Nothing less. You have to go and study this part. Okay. MDR-TB. So I was shocked why this question is being asked repeatedly for 5-marker, even in community or medicine. Problem is that the major cases, if you see the epidemiology part of it, major cases which is there in our community is MDR-TB. So you need to know how to manage MDR-TB. Though for tuberculosis, I will say 88. So it's something which you should know. Again, what important thing is that I'm sure I'll be uploading the PDF. There's nothing more you need to study. How do you give the drugs is what you need to study as an extra part of it. Okay, which I have mentioned here. For isoniazid resistant TB, again, you start with all these things for 6 weeks. Okay, all the one thing which you are adding is levoflox. Make sure you know the groups also very well. Okay. Then extended dots is for MDR-TB. Okay. So this is what the 5 things which is there. And then Montauk test, which I'm sure you know it. Again, write the procedure, interpretation. Again, if it's more than 15, then it's strongly positive. More than 10, positive. Then 5 to 9 is equivocal, but less than 5, you can consider it positive in immunocompromised patient. These are the pitfalls, that is where you find false negative and false positive. And bronchogenic carcinoma, it's a potential 10-marker or a 5-marker. Make sure you know that. Okay. Again, while writing oncology, what do you write? Generalized fever, weight, general features, you write weight loss, anorexia, cachexia, all those things. Then again, clinical feature might be due to local growth, local invasion, or metastasis or paraneoplastic syndrome. This you have to mention that, because it's known to cause paraneoplastic syndrome. So you need to mention that. Again, same thing. Again, these are the things which are, whenever you are writing oncology, what are the treatment options which you have? Radiotherapy, chemotherapy, then surgery. Based on the stage, you go with it. Okay. And like in acute lung abscess, again that neutrophils is being settled there in the lung, so it's causing an abscess. Again, whenever you see an abscess, it's ideal to drain. But here what they are important, what they are expecting you to know is that about the complication part of it, again divided into system and just present. These are the aims, which I'm sure you can study on your own. So these are the causes of hemoptysis, again divided into causes, and whenever you see an hemoptysis, again you have to think about systemic. Then clubbing also, in and out, I'm sure you know. And also Horner syndrome, what are the components of it? Now I think there's nothing much to discuss. Ptosis, meiosis, and anastosis. This is the topical pulmonary eosinophilia thing, where you see increased serum IgE. Okay. And this is what is given in Archie Buller. Okay, so they might ask you about type 1 and type 2 respiratory failure difference, so make sure you know that part also. And this is the modalities on how you can start giving oxygen. First you give oxygen therapy, then you give high flow oxygen, then non-invasive ventilation, invasive ventilation, then extracorporeal oxygen delivery. Okay. Then one more topic which I had left was pleural effusion, because I'm sure you would have studied in wards. So these are the common, uncommon causes. Management, again you go with slight criteria. Then if it's check whether it's transudative or exudative. If it's transudative, again treat the underlying etiology like CHF, nephrotic, and all those things. And if it's exudative, look for whether it's malignancy part or something else. If it's malignancy, you need to treat the cause. So there's nothing much, so I've not discussed much. Okay. Then coming to the next important chapter, which is very conceptual, but if you are studying a day before exam, then I would ask you to just focus on anemia part and ITP and hemophilia part. Though leukemia you cannot study a day before exam, you should know the concept, but I have just given you the notes. You just go through that and you can place the decision. Complete. 3 markers are these things which are asked repeatedly. Then again, while understanding the concept of anemia, you should know RBC has, again this is from pathoma, this is not something which I know, I learned from pathoma. So RBC is made of what? Heme, which has iron and protoporphyrin and globin. So if this has to reduce, then it might be due to iron deficiency anemia or protein deficiency or globin defect in case of thalassemia. But microcytic hypochromic anemia is consistently seen with thalassemia. And also you might have iron deficiency anemia because iron is not there. Then also sideroblastic anemia, then anemia of chronic disease, because iron is being used as a inflammatory marker there. So make sure you know the concept before you even study. Then you make a mnemonic like Sita and or something, whatever you know. Then make sure on the day of exam you have to write it spontaneously. But whenever you are asked, you should be able to explain the theory or the concept behind that. Then again, etiology, any iron deficiency anemia in the male is due to gastrointestinal, unless proven otherwise. It might be due to hemorrhoids or it might be colorectal carcinoma, but it's something which you need to take home. Though my preliminary aim is to make sure everyone get good marks, but if you don't have clinical concepts in mind, it doesn't serve the purpose, right? So make sure you know whenever you are treating an iron deficiency anemia, especially in case of male, it's usually due to bleeding, because the iron utilization part in our body is very well. Then these are the conditions where you need to just mention intake is always lost, man. Okay. Then this is the important thing. Then again, the clinical feature and examination, I'm sure you know. Then how to estimate it, and how to go with this to exclude other costs. This is the major thing which I would say. Then how do you go with iron therapy? I think you can just study that part. And basically, clinical speaking, it's very good if you go with total parental nutrition with that is a parental part with iron, that is IV or IM, so that compliance is, because the compliance here is very poor, man. And to replace the iron stores will take much more time. So it's better you go with carboxy maltose or something where you can replace the iron stores for 6 months and you can have a disease free life. Then most important thing is megaloblastic anemia. Again, it might be due to all these things. Okay, I've explained B12 and I think B12 and B9 is something which you all know from first year, so I'm not explaining that part. The anemia part is again from a template, cause again based on your pathology thing. Then again, investigation to know the diagnosis, to exclude other cause, and to look for complication. Make sure you write in the same template. And clinical feature, it's a B12 is a neuro vitamin. So again, you have to talk about nerves and cerebellum. Okay. Hemolytic anemia, again there is a concept here. Again, it can be either inherited or acquired. So what happens is that if an RBC has to be destroyed, it might be destroyed due to internal instability. Okay, or an external force or an external instability. For external instability to happen, it might be due to an immune attack or a non-immune attack. Correct. So again, if it's an immune attack, that is, if it's an external, then you might have either immune attack or non-immune attack. If it's an immune attack, again, it might be due to from your own antibodies, or it might be some others, as you've seen hemolytic disease of newborn. Or again, antibodies either can be either warm or cold. Okay. Make sure just these basic things you have in mind. Then non-immune, again you might have again infective, inflammatory, mechanical, then again abnormal conditions like PNH. But inherited, what inherited is something, there might be problem in your cytoskeleton, there might be problem in your enzymes, there might be problem with your globins itself. Okay, cytoskeleton, enzymes and globins obviously sickle cell and tau. Then enzymes, because what is RBC gaining energy from? Not from glycolysis, because it doesn't have that hormone. It has to go with, it's a G6PD predominant pathway, so you should always have antioxidants. So G6PD is one important thing, and also pyruvate kinase deficiency, and also RBC membrane defect, as you see in hereditary spherocytosis and erythrocytosis. Then these are the investigation to check for hemolysis, whether it is happening or not. So all this will increase. Then to check whether RBC production is being increased. Then also all this basic investigation. Aplastic anemia, again it might be due to inherited and acquired. These are the treatment part, but this is one of the bad diagnosis which you can offer to the patient. Make sure this is the definitive treatment. Make sure you know that part as well. Okay. Then bone marrow transplant, these are the indication and these are the complication. Make sure this part you study well, because it's a potential 3 marker. Then what are the basic things? Leukemias, it's a very big concept. I would recommend you to go and see conceptual videos, but I've just mentioned you what are the things which you need to write. You have to mention about WHO classification, though FAB is acceptable, but it's of no value to prognosis. Okay, so make sure you study this part well. And again, management part, again you have to treat all the underlying condition, you have to treat the complication, then you have to destroy all this leukemic regimen, and you give the 7+3 regimen, and you have to induce a microscopic residual disease free thing in this leukemia part. That's it in hematology. Make sure first thing which I have not mentioned about hemophilia and ITP, because it's an important pediatrics topic. I will be discussing that. So make sure when I upload that video, you go back and watch that part. Okay. So make sure you study that. Okay. Anemia, the hematology majorly they focus for 5 marker or 3 marker, but also when sometimes they have asked for 10 markers. That is only the anemia part. So there are 3 components. That is anemia. Then it might be due to a plate, that is leukemia, or something related to platelet or coagulation. Platelet and coagulation, although the major competencies to test under pediatrics, sometimes they are asked in medicine as well. So make sure you study that from there. But for 5 marker or 3 marker, again for 3 marker, indication, contraindication type of question is being asked. Then etiological factors, and again for 5 marker, either IDA, that is microcytic hypochromic anemia, or megaloblastic anemia, or hemolytic anemia, which is being tested. So this is the last part, that is infectious medicine. The problem here is that though it's a 16 mark paper, again as I told, I have divided into 3 parts because this is what is given in single. What I feel is Davidson alone is not enough, man, for this, because it's very less. Let me be very honest. So I would recommend, though in this part I have just given out what is given in Davidson, I'll make a separate video where I'll be explaining some important other concept which you should know before you that is kind of part 2 of paper. Okay, so part 3. Okay, so where I'll be giving elaborate notes or what I'll be doing it further. So for now you can study about all these things. So for 10 marker, as I explained, typhoid is common, dengue is common, malaria is common. Okay, again PO for 5 marker. Okay, I have not written much. Okay, yeah, again you form the same template. Again you have to go with where there's notes. Okay, etiology, then clinical feature, investigation, then management. Again management aims are same, infection diseases. Again you have to go with microbiology. Again whatever you have studied there, first thing is again microscopy for all bacteria. You might have light microscopy or immunofluorescent microscopy. Though it's not done, then you have to go with culture. Then again serology, that is you can either test antigen or antibody. Okay, so antigen appears first, then antibody. Then again you have all this viral marker ka BAP, that is PCR, CBNAT. Okay, make sure you study under that so that you know what to study that part. Okay. So again, PO, it's a potential 5 marker if you ask me for that matter. So what they expect you to know is the etiology and the workup for it. Though at the end many of the PO goes undiagnosed, that means you won't find any other etiology. Make sure you know the etiology, where you can give a proper diagnosis to patient. So again, definition, etiology, again most of them are idiopathic, again divided into infective, malignancy, CTD is being tested now. Then also miscellaneous part. Then investigation, again what are the initial investigation you do to rule out the infective part. Then the serology part, again which I discussed. Then you try to find the foci. Whenever you see a fever, again you have to divide it into what, in any OPD cases you have to check for foci, whether it's UTI or whether it's RS or whether it's again upper or lower, whether it might be upper or pneumonia, or again it is something to do with GI. If you know, don't see the foci, again go with all these things. The prognosis, again as I told, the same thing. Dengue hemorrhagic fever, I will not recommend you to just write this, okay? No, you have to write more, but to know the things, again to give you the same template of what is given in Davidson, this is what he has told. Okay, again fever, rash and convalescent phase, and these are the complications which are present. Again, to diagnose these things, I think you will know this by all this, but the major thing is you have to check for complication based on hematocrit, the management changes. Okay, so again you have to while writing the treatment part of it, make sure you write all these things. Again, Weil's disease or leptospirosis, potential 5 marker. So again these are the phases. Okay, it's what it might first give generalized features, then you might have all this aseptic meningitis kind of thing, then icteric leptospirosis, then you go for pulmonary leptospirosis. These are the investigations. I'm not talking much, but major thing is fluids. Any viral fluids and symptomatic. Though this is not a viral disease where you can start with doxy. Okay. Enteric fever, this is not given in Davidson. I just made my own thing where what are the clinical features which you can expect. So complication part you should know well. I'm sure you know this part. Then the investigation, again to diagnose and to confirm the disease. These are the management. Obviously I have to write more. I'll make sure I'll upload a separate video on that. Malaria, again for a 10 marker thing. Though I have not written management part. Make sure you, for this you study a proper local medicine textbook like Alchipula, Manipal. Okay. These are the complications that can ask, and you need to treat accordingly. This is the chickenpox for 3 marker complication, and HIV. Make sure this is a potential 10 marker bar 5 marker, so you should know in and out. Okay. Again, AIDS. This is for 3 marker, if I'm not wrong. For know the pre-exposure prophylaxis, post-exposure prophylaxis of AIDS. It's a 3 marker. Then pathogenesis, this is what is given in Davidson. You can just refer, though it's not important under medicine. You should know to know the drugs, you should know how to start. Then CDC classification, you have A, B, C. That is, C is age defining. Then A is asymptomatic. B is symptomatic condition which is not present. Okay. Again, investigation. Again to diagnose and to treat other conditions, like it might be associated with syphilis or HP, that is hepatitis, all these things. Then treatment aims to decrease the virus load, then to improve the CD4 count, to prevent opportunistic infection, and also importantly counseling. Then the regimens, obviously you give it what, to so I have to either give to NRTI plus any one other class of drug, where I remember it as DAL, where you can give it dolutegravir, abacavir and lamivudine, or all these regimens. Then opportunistic infection in AIDS, again you have a beautiful diagram in Apurva Shastri, make sure you refer that. Then again divided into infection, viral, bacterial, fungal and parasitic. So based on that, based on the CD4 count, make sure you write this. This is the graph which I have made. Okay, whatever I have done, I have done. If it's from Davidson, it's from Davidson. If it's from ChatGPT, it's from ChatGPT. If it's from me, it's from me. If you want, you can write, or you can make sure you write this. Okay. But this part is very important. And CD4 count, mentioning about CD4 count itself is important. Kaposi sarcoma, again it's a low-grade malignant tumor. The management part is important. While writing management, while writing treatment, make sure you write aims to screen for HIV and treat if HIV is, start with ART if HIV is present. Then again, for if it's a systemic, then you have to go with liposomal doxorubicin. If it's a local, then you have to go with local application like intralesional chemo or the surgical excision. And again, STD, syphilis is the favorite question, man. After that, you can start with Sancroid or LGV, which I'm sure you can just write it down on the day of exam, because there's nothing less because you are studying it from first year, second year. Okay. This is the causative organism. These are the stages. Stages is something which they expect you to know. Primary, secondary, and tertiary syphilis. These are the clinical features which are present in it might be neurosyphilis or severe syphilis or rare syphilis. Congenital syphilis का components for 3 markers they can ask. This is how you test for syphilis, and also treatment. I'm sure you know the benzathine penicillin part. So this is what I wanted to say you in paper 2. So though the paper 2 part of it is more of, if you ask me, has lot of unpredictability. So and as I told, it's a paper which plays with your subspecialty and super specialty of medicine. For example, super specialty involving your hematology, that is medical oncology, nephrology, all those things, and subspecialty infectious medicine also, and neurology as well. Then this itself as chest medicine and TB and dermatology, psychiatry. The knowledge which you can accumulate here is immense. But a day before exam, it's your key to know what you should study and what you should not study. These are whenever you're studying, make sure that single thing everybody will do, and see the cutoff, what are the number of questions which are being asked. Based on that, you predict question. Based on that, you have your template in mind. Based on that, you study all these things and you go. I'm sure you can do better. Okay. And remaining topics which I have not covered in this part, I will be uploading even for paper 1. No? There are a few topics which I have not covered because I thought it's less important. But again, after, what was the aim? First aim is to pass the exam. Second aim is to get good marks. Correct? So for that, to get the good marks, I will make sure I'll make that separate video. But now, I think to pass the exam, this is more than enough. If you study in this order, and if you present the same same template, for example, dermatology, as I told the management, same template, general, then consider all these things, then consider PUA, then consider immunosuppression for management of any of those conditions. For psychiatry, again, for etiology, again go with the community medicine thing, genetic, environment, social. Based on that, again you do other things, and again, by writing management, you have only 2 drugs, that is antidepressant or the mood stabilizer thing. Then again, you need to know the side effects of all your all your antipsychotics, and also indication, contraindication of everything and anything in this system. So important thing what I would say is, make sure you know things, okay? And if you don't know things, make sure you know the general things. For example, as I told, in dermat and psychiatry, and try to fit it in and around it. So that aim is to, if it's for a 5 marks, 5 mark question, and if you don't know anything, aim is to fetch what, 2 or 3 mark. Though if you know everything, you'll get just 3 or 4 mark. Aim in not knowing a question and fetching 2 and 3 mark is an art which you should know, which I have tried to explain in this part. So that's it for part 2. I know it's very huge. Make sure you study systematically and you present systematically. On the day of exam, don't panic. Whatever, even if you don't know, make sure you fit it into template and come back. Okay, that's it. Thank you.